Good morning, everyone. And today, this is the last lecture for diagnostics. In this one, we are going to talk about the rest of the modalities. And now, uh, of course, like in all the previous lectures, we were discussing about the ECGs, which are the most important investigations related to cardiology. And in this one, like we are going to talk about the rest of the investigations, not too much, but or not in too much detail, just to give you an idea what are the different things which are available. So one of the investigation which is done too commonly, it is called as echocardiography, and now at this level or in at undergraduate level, of course, like they will teach you in radiology about a little more in detail about echocardiography, but at this level, you can say it's not required that you have a detailed knowledge of echocardiography. However, it is important that you must be familiar with what is echocardiography and what are like the reports and sometimes, very, very sometimes, like just to how to interpret them. So now, for example, what is echocardiography? I will show you over here. See, like this is a person who is performing a echocardiography, and see he have put a probe on the chest of the patient, and this probe or echocardiography have the same what you can say uh, basis or we do ultrasonography, right? So ultrasonography uses sound waves, so this one also uses sound waves, right? So you can see over here, or by the way, there are two type of echocardiographies. This is transthoracic, because see we have put we they put he put the probe on the thorax, and there is transesophageal as well, in which like what they do is uh, uh, transesophageal. They put the probe through the mouth, okay, through the mouth, uh, inside the esophagus, and now this probe can see the heart. Okay, so this is like transesophageal, which is also called as TEE, transesophageal echocardiography, and the previous one, which is transthoracic, also called as TTE or transthoracic echocardiography. So you can simply say that there are two kinds. One is called as transthoracic echocardiography, and one is called as transesophageal echocardiography, right? Now you can see this is the basics, okay, and how the image is generated. It looks like this. These are the atriums, and this is the ventricle. This is the walls, okay. So basically, the good thing about echocardiography is like it is. Uh, like what it can do or what we can do by doing echocardiography. Number one, we can check the size of heart chambers. Okay, uh, so for example, what are the different chambers? There is atria, there are ventricles. So uh, of course, like the normal values are written over here, over there in the ECE echocardiography report, but it is helpful in measuring the size of the chamber. So, for example, the normal maximum diameter of the left atrium is around 4.5 centimeter. So, whenever it is enlarged, for example, in atrial fibrillation, it can be seen by echocardiography. The normal maximum diameter of the left ventricle in diastole is 5.5 centimeter. And whenever for example, the left ventricles are either hypertrophy or they are dilated, it can be catched by this thing. Uh, so we can also check the ventricular septal thickness. Okay. Now this one, like the septum, which are between the two ventricles, like this is normally less than 1.2 centimeter, but sometimes it can be thickened as well. For example, in the cases of HOOCM, hypertrophic obstructive cardiomyopathy. Other things which we can check is left ventricular function. Remember, the ECG just notice the electrical activity, but this can check the structure of the heart. So how the walls are moving, what is the ejection fraction, like the normal ejection fraction is around 65%, so we can measure it by echo. uh, we can check the details about every valve, like mitral valve, tricuspid, aortic, and pulmonary. So if there is any regurgitation or stenosis in any of the valve, and we can check we can measure the size of the each valve area. So based on that, we can classify either someone have a mild stenosis, moderate stenosis, or severe stenosis. We can also catch the vegetations. Okay. uh, for example, in infective endocarditis, I told you guys like there are vegetations on the heart. We can, or tumors also. Okay. So that's why this echocardiography is very very useful in patients of um, infective endocarditis. This thing, and one of the thing is like we can estimate uh, of pulmonary artery pressure by echocardiography. Okay, so simply a pressure of more than 35 millimeter of mercury suggests pulmonary hypertension. Okay, so we can estimate it by echocardiography. We can see any if there is any pericardial effusion. Okay, so that can be seen. Of course, in that one, like we will see that they have water around the heart or in the pericardial cavity. So this is like about echocardiography. Then there is one modality which can be used, like CT or MRI of the heart can be done. Now, uh, this one is mostly done in patients who have uh, suspected cardiac disease. Okay. Now, CT assessment of the coronary arteries, nowadays, what we can say is very, very, very becoming very common. That is, I will show you CT heart. Okay, CT of the heart with calcium scoring. You can see over here. Okay, they like the report comes like this way. Okay, so you can see like here they are showing some coronary calcium. So nowadays this calcium scoring CT, it is increasingly in used. Okay, because it can calculate or do the assessment of the coronary arteries, and what you can say, uh, this is one of the way or non-invasive way to check like the condition of the coronary arteries. For example, someone who is presenting with chest pain. So same like with MRI of the heart can provide detailed information of the structure and the function of the heart. So, but of course, like how to interpret them, it's a specialist domain, radiologist or specialist cardiologist, they do this thing. Okay, but the good thing is like whenever they do this thing, they write a report. So the doctors can read the report and they would know, okay, what is the real thing going on. Uh, Other than that, um, there are some dynamic testings of the heart also do. We can do dynamic tests in cardiology. So now, for example, someone who is presenting to you by chest pain, or who is presented to the doctor by chest pain, right? Now, uh, wait. So what we do, by the way, like now we don't know either the person have any angina or whatever, right? So what we can do, like we can, of course, like what is angina? Uh, Wait. Okay. So what is the thing is simply now we don't know like either it is angina or something else. So uh, we will go for some dynamic heart testing to investigate that chest pain, right? So now in the resting state, when someone is resting, a patient or a person with atherosclerosis. Now atherosclerosis, what it do, it basically narrow down the coronary arteries, right? So now at rest, like they have the normal ECG. They don't have any chest pain, they don't have any symptoms. But when we have, we will put the same person in stress. Stress, I mean to say stress uh, by we will let them do some exercise, right? So now, when the person, for example, this lady, you can see like she is on uh, this bicycle and she's going to move it, or for example, you can see over here uh, a person who is on treadmill and they put a ECG on that person, and see the monitor is also using the checking the ECG changes when the person is doing exercise. So simply when we put the person under exercise, what will happen, that they have like this person heart will, for example, for sure like beat faster and pump faster, and simply the energy requirements of the heart will be increased, or simply the heart requires more blood supply. And if the arteries are having atherosclerosis, what will happen, the like that arteries cannot supply enough blood. And when this is the case, what will happen, that the person will be having either a chest pain, or either we can see the ECG changes over here. Okay, so this is the basis of this. This is also called as exercise tolerance test. Okay, so now, uh, just to tell you, for example, this person, if he have angina or anything like atherosclerosis, what will happen, that we can see the changes over here, no matter he is feeling pain or not. For example, maybe he will be having ST segment depression or elevation. Okay, so this is one of the thing. Um, of course, like nowadays there is a lot of dynamic tests which are available, but for example, what we can do if someone who cannot do exercise. Okay, if someone cannot do exercise, we can use so one of the thing is exercise tolerance test, right? Okay, which I'll show you. One thing is, if the person, if the patient cannot exercise, of course there are many patients like who are bedridden, they cannot do exercise, then we do something called as um, chemical stress. Okay, like we can give them a drug like dobutamine. Okay, now dobutamine, what does drugs do? The dobutamine, it increases the heart rate. So when the heart is now beating faster, so what will happen, like again the heart will come under stress. So then we can give them dobutamine, and at the same time we will do a ECG or echocardiography. Okay, so nowadays, by the way, there are some new ways also available. For example, uh, nuclear imagings, imaging techniques are also available, are also available or increasingly used, right? So nuclear imagings are used, and simply we give them some type of contrast, and we see uh, like the cardiac muscles, either they are taking up and how much they are taking up, right? So these tests can be used as well. This thing, and then like last but not least is the cardiac markers. Cardiac markers, very important topic, but again, uh, maybe you like it will be hard for you to understand completely, but simply whenever the heart is damaged, okay, so like when I say heart is damaged, what I mean to say is heart muscles is damaged. So the heart muscles have again the same contractile proteins, and some specific contractile proteins. So one of the proteins which heart muscles have, or contractile proteins which heart muscle have, is called as troponin. Okay, so there are two types, troponin I and troponin T, right? So nowadays, troponin I and T are the tests which are most commonly performed to assess uh, performed to assess myocardial damage. Okay. Now, you like what I mean to say over here is, I will show you cardiac markers over here. Cardiac markers, right? Okay. For example, see, they are showing you a lot of cardiac markers over here. Like again, like okay, I will save it, and I'm going to show you in the slide, right? I will include this image in the slide. You can see like a lot of things are shown over here. Okay, okay, wait, leave it. Okay, see, like these are different cardiac markers, right? There is myoglobin. Okay, these are the time in days, and these are their levels, and this is CKMB, which is the blue one. Then there's troponin I, the purple one, troponin T, the green one, CK, and LDH. Now, the thing is, of course, like we must select something out of these. Number one, which are just meant for heart. For example, CK is present in heart muscles as well as skeletal muscles. So, no matter either it's heart muscles which are damaged or other muscles which are damaged, LDH can be raised in multiple conditions, right? But that's why, troponin is normally involved in the cardiac muscle contraction, and it is and it is released whenever the cardiac muscles are damaged. Now, troponins, if you will see over here, purple and green lines, uh, they, okay, this is one day. So basically, they start elevating uh, within 1 hour or after 1 hour, and they can stay elevated up to 7 days. That's the important thing, guys. Okay. So levels of these we generally measure uh, around 12 hours. So 12 hours is this much, okay, after the patient is presenting with symptoms. Okay, so nowadays, by the way, they are using a high sensitive troponin, which are increased even before the previously done troponins. So, but again, one of the thing, like troponins, they are not too specific for the myocardial uh, infarction, or you can say heart muscle damage. Like for example, there are many other conditions in which troponins can get raised. For example, I will write over here, uh, can be raised in now myocardial infarction, for which we are using, right? But they can also be raised in heart failure. They can also be raised in myocarditis. Now, of course, like all these are heart related condition, okay, or heart muscle damage is going on, but they can also be raised in patients who have pulmonary embolism, okay, as well as they can also be raised in renal failure. They can also be raised in sepsis. They can also be raised in supraventricular tachycardia. So now it's not just troponins which we measure, but we can use some other enzymes as well. Because you can see like different enzymes, they peak at different times and then they go down at different times. For example, CK, right? So the CK peak within 24 hours. Okay, and they go by two or three, second or third day. Okay, there is AST also, there is LDH also. You can say, like, no, LDH, if you will see the story of LDH now, they take around, like, they maintain the peak, you can say, for quite a long time, right? So CK, creatine kinase, or CKMB, this is also released from the black one and the light blue one I'm talking about. If you'll see the blue one, they are also released from the damaged skeletal muscles. And so that's why, any patient who have myocardial infarction or myocardial damage or trauma, even, like, they will be raised. Okay, so this is like how we go. So this CKMB, guys, this is isozyme. Okay, uh, and this one is mainly for the cardiac muscles, CKMB. Okay, so whenever this one is raised, of course, it is a clear cut suspicion of the heart muscle damage. So that's okay. No, 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 that's all. I can talk one more thing, but just taking a little time. That is called as um, B type natriuretic peptide. Okay, now this is also called as BNP, simply the short form of this thing. Okay, BNP, B type natriuretic peptide. So, what happens in heart failure? If you know what is heart failure, a general idea, simply the heart chambers are stretched more than normal. Because why? Because there is fluid overload. So, in such circumstances, what happens? Like uh, the body start producing some hormones or some substances that are meant that they must increase the sodium excretion, or natriuresis, sodium uresis, like expelling that from the body, of course, like in an attempt to improve the uh, volume of the blood. Okay, why? Because in heart failure the volume is increased, there is stretch on the heart muscles, so there should be something which is released, which will lead, or which will let the sodium excretion. Okay, and this is basically the thing which do that function, BNP. So it is released due to stretch of the heart muscle. Okay, now uh, basically it is present in the body in a inactive form, that is called as N terminal pro BNP. Okay, so you can say a non-cleave form, right? N terminal pro BNP. So now BNP, of course, it will be raised in patient of heart failure, right? But BNP, as well as its non-inactive, you can say, cleavage fragment and terminal pro BNP, will be elevated in the patients of heart failure. Okay, uh, but if, for example, someone who's like these levels are normal, so of course, like, you can say, like, the person is not a patient of heart failure. Okay, like, simply for example, like, I will just tell you, like, told you when it will be released, right? For example, if someone have a normal ECG, okay, with normal uh, BNP levels, or you can say N terminal pro BNP levels, simply, right? Pro BNP levels. So you can say, like, when someone have this thing, you can say that, uh, wait, you can say, like, heart failure is not likely. Okay, well, like, there are very low chances of having heart failure. So, guys, that's all. And uh, like, at your level, I think, like, if you can cover these things, that would be very nice, and it would be very helpful for you guys, right? Rest, like, of course, that's the end of diagnostics, right? And I hope the things are quite easy for you. So thank you for listening this one, and I will see you next time in some other lecture. Thank you so much.